Hey guys, welcome. Hope I'm audible and visible. Uh, Okay, so let's go with the final thing about the study with me series in pathology. Like we had a quick discussion about RBC disorders in the first 2 days, and we had a discussion about the normal B cells journey yesterday. Hi Nagu. And today we'll be discussing about a few things about leukemia. And I want to again go back into the very rock bottom basics and to understand few things regarding leukemia so that we won't miss any higher end stuff, fine, reading the brush. And tomorrow I think there will be an quiz regarding RBC WBC disorders. Might not be the same thing what we are reading here today, just to test your knowledge, and if you are in the top 3, you might be the lucky person to win the Amazon, which is fine. So on that note, let's go and have a quick look about leukemias. Here, Friday at 9 p.m. I hope the quiz time is also visible that they brush. Good evening, Path. Hi, Amit. So today we are going to have a look about leukemias. Fine. So I'm sure that you must have read about leukemias in different places, right? So what we are going to see here is I'm trying to go and give reasoning for almost everything what we read about leukemias. Fine. So when you have leukemias, we divide the WBC neoplasms into leukemias and lymphomas, right? That's the normal way by which we divide my WBC neoplasms. Fine. Hi Adi. Okay. So here we name a few diseases leukemia by lymphoma. Do you have any disease which comes on the top of your mind where you call something as leukemia bar lymphoma? Anything? Hi there, Priya. You must have read about CLL bar SLL. We call them chronic lymphoid leukemia and a small lymphocytic lymphoma, right? So when do we name something leukemia and when do we name something lymphoma? Something which is very, very basic thing which I want you to understand. ALL, that also is correct, right? We call it acute lymphoid leukemia by lymphoma, right? For T-cell, adult T-cell leukemia by lymphoma. We have few of them as leukemia and lymphoma, right? So I'll term something as leukemia. It's totally based on the origin. It's not based on the disease where it is present. It's based on the origin. If it is originating from anywhere in the blood or bone marrow, I use term leukemia. If the same origin is from, again, totally should be in the origin, from any solid reticuloendothelial system. Okay. It's not your lymph node alone, any solid reticuloendothelial system, which I mean if it's coming from spleen, if it's coming from your thymus, if it's coming from liver, any solid reticuloendothelial system, I'll call it a lymphoma, fine. Now it's not about involvement. As I said that I don't care about the involvement, I always care about the origin only, right? That's one misconception we see, that if both lymph node and bone marrow is involved, I call it a lymphoma or a leukemia, right? It's the origin. If it's going to be originating from this, I call them a leukemia and a lymphoma, that's all. Why I don't want you to know that it's involvement, let's say that Hodgkin's lymphoma, it is a lymphoma, right? Can I say that Hodgkin's lymphoma will involve the bone marrow? Will follicular lymphoma involve the bone marrow? It will. If it's a lymphoma, if it's originating from the lymph node and it's going to involve the bone marrow, I call it a stage 4 disease. Okay, I call it a stage 4 disease, fine. So I don't based on the involvement, we always base them based on the origin, right? It's not about the considered overlap. The overlap stays in the origin again. When we take CLL, in CLL we have origin in the naive B cell, like what we saw yesterday in the routine B cells journey, and it can also have a post-germinal center origin. So the origin overlaps. So I call them a leukemia by lymphoma. Same with ALL. When I say ALL, can it originate from the thymus? TALL can come from the thymus, right? So I can have a leukemia, ALL, coming from the blood circulation, as well as it can come from thymus. So I call them an acute lymphoid leukemia by a lymphoma, right? It's always based on the origin, okay? So this is one basic things for me, right? Second thing is, we look at the leukemia per se. When you take a leukemia, I'm sure you know that we divide leukemia as acute leukemias and a chronic leukemia. Anywhere we use this classification, acute or chronic, what do we base them on? We always call something an acute or chronic based on the timeline of events, right? If it happens immediately, I'm going to call it an acute inflammation or any acute disease. Chronic means it's going to happen, it's going to stay there for years together. That's what we use acute and chronic for. But in leukemia, I don't call it based on that. We call anything an acute leukemia if the amount of immature cells are more. What do we term the immature cells in a hematolymphoid lineage as? We have something called as an immature cells. What do we term them as? We call immature cells as blast, right? In other words, I'll call anything an acute leukemia if the amount of immature cells are more. Immature cells, or in other words, blasts. The blasts are more, I'm going to call them an acute leukemia. In chronic leukemia, doesn't mean that blast should be absent. It should be a combination of both immature and a mature cell. Let's take my WBC lineage, the neutrophilic lineage. The neutrophil, your band forms, all this are my mature lineage, myelocyte, metamyelocyte, right? So in a chronic leukemia, I'll have both immature and mature cells, right? Same goes for my chronic lymphoid leukemia. I'll have immature pro-lymphocyte plus I'll have lymphocyte also. The lymphocyte should be predominant. See, immature cells are common for both acute and chronic leukemia, which means I need to have a cutoff, right? Only if I have a cutoff beyond this, I will call it an acute leukemia. If it's not there, I'll call it a chronic leukemia, right? The cutoff for an acute leukemia, I'm sure you must have read this. For any acute leukemia, whether it be lymphoid or myeloid, what is the cutoff? Beyond this many blast percentage, I will call it an acute leukemia. What do you think is the cutoff? It is more than or equal to 20%. The most important thing here is it should be either in the bone marrow or in the peripheral smear, right? It's not both, it's either or. If it is either in the bone marrow or in peripheral smear, that's more than enough for me to call it an acute leukemia. It is always 20%, right? I wanted to take time here and address a controversy which has been roaming around, saying that for an ALL, which is acute lymphoid leukemia, we consider 25% as the cutoff criteria. It is not 25%, right? I'll tell exactly what WHO says. The reason why this confusion came is Nelson pediatric textbook has somewhere mentioned that 25% is the cutoff for your diagnosis of ALL. It's a pathology based thing, right? It's a diagnosis. Diagnosis should not be taken from Nelson. You don't take treatment from Robbins, right? So we have certain books for the certain specialities, right? So diagnosis always should be based on WHO or any pathology textbooks, right? So what Robbins or WHO says is, for a lymphoid leukemia, generally I don't require a cutoff for ALL, right? For ALL, generally I don't require a cutoff. Why I don't require a cutoff is the amount of blast percentage in ALL will most of the time be 70s or 80s. I don't see any acute lymphoid leukemia with a blast of 20 or 30. It will always be high only. So I don't require a cutoff. It also follows up saying that if you want a cutoff, take more than 20%. There are few treatment guidelines which consider more than 25% as a limit to evaluate the response to therapy, not for diagnosis. That percentage for response to therapy. For diagnosis is always going to be 20%, and for anything related to diagnosis, I want you to go with your WHO or any pathology textbook, right? So both for ALL and for AML, I'm going to consider them 20% only, right? So you have bone marrow or in a peripheral smear, right? So why this either or is important for me is, so I can have two more subdivisions based on the number of percentage in my bone marrow and number of percentage in my peripheral smear. I have a term called as an SubLeukemic leukemia. Okay, so just variations, that's all. We have something called SubLeukemic leukemia. When do I call something a SubLeukemic leukemia? Is the amount of blast percentage in my peripheral smear is less than 20%. Let's say that, we'll give an example. I'm going to diagnose, let's say, an AML, where my myeloblast in the peripheral smear is 15%. I want a bone marrow here, right? I cannot sure diagnose 15% blast percentage as a leukemia. So when I did a bone marrow examination, the amount of blast percentage here is, let's say, 35%. So can I call it an acute myeloid leukemia? I can call it an acute myeloid leukemia. But in peripheral smear, it didn't reach my 20%. So I call this in SubLeukemic leukemia. Fine. There's one more term called as aleukemic leukemia. See, leukemia means white blood, that's all. When will I call something an aleukemic leukemia as? Again, we'll take one more example. Again, I'm going to think about a case of an AML. In peripheral smear, it's completely normal. The only finding I see in peripheral smear is pancytopenia. It's pancytopenia, there are no blasts. You're having a patient with the pancytopenia. Will I require a bone marrow examination? Yes, right. When a patient is pancytopenic, I do require a bone marrow examination. So when I do a bone marrow examination, in the bone marrow, I'm having, let's say, 45% blast. Can I call this or diagnose as an acute myeloid leukemia? I can, right? So when I say aleukemic leukemia, it is a leukemia, but in peripheral smear, I'm not having blasts, so I call it an aleukemic. It's absent leukemia in the peripheral smear, but definitely it's a leukemia, right? So these are two variations of a routine diagnosis of an AML. I can have subleukemic, I can have an aleukemic leukemia. I can have this for both ALL and AML. Regardless of that, I'll have both AML and AML. I can have this, fine. So now we know about a little bit about my basics of leukemia. First, we'll look at AML, and also we'll look at ALL subsequently, fine. So we take an acute myeloid leukemia. What are the subtypes you know in acute myeloid leukemia? I'm sure you must have known many subtypes in an acute myeloid leukemia, right? You must have heard about AML M0 till AML M7, right? What does AML M7 stand for? AML M7 stands for your megacryocytic or megacyoblastic leukemia, right? We call it myeloid, but still I have megakaryocytic. AML M6 is erythroleukemia, M4 M5 is monocytic component. That's kind of contradicting for me saying that it's myeloid. Myeloid means, as per my knowledge, myeloid means WBCs. I don't, especially granulocytes, I don't think of a megakaryocyte or an erythroid as a myeloid, right? So to understand the subtypes of leukemia, I want you to go to your erythropoiesis. So when you go to hematopoiesis and erythropoiesis, we have a common cell called an pluripotent hematopoietic stem cell. That's a first cell. Then you have multiple stem cells, the multipotent and everything, that will also come into place. Then what happens is, very early, I have a division called as a common myeloid progenitor and a common lymphoid progenitor. I'll have common lymphoid and I'll have a common myeloid. Okay. All leukemias comes from this progenitor only. Okay. Leukemias are tumors of the stem cells. So this progenitor, I can have a leukemia. Can I have a leukemia from my pluripotent hematopoietic stem cell also? I'm having a mutation there. That also can give rise to leukemia. I can have a mutation here. This also can give rise to leukemia, right? So when I have lymphoid progenitors, these gives to my B cells, T cells, NK cells. This is the only thing what my early lymphoid progenitor gives. A common myeloid or an early myeloid progenitor, what it gives is, it further subdivides into colony forming units called as CFUs, right? I have CFU basophil, CFU megakaryocyte, CFU erythroblast. That's one. Basophil, megakaryocyte, erythroblast. Other one is CFU mixed. Okay. When I say this three, this will give rise to, as the name says, basophil, megakaryocytes or platelets, or an erythroid or an RBC. Fine. The CFU mixed gives my granulocytes. In general, when I say granulocytes, I call them only as neutrophils. It's not all the granulocytes. For all intents and purposes, when you're discussing about leukemia, granulocytes means neutrophils, fine? So I have further granulocytes. It can give me my granulocytes, which is neutrophil. You must have heard about granulocyte colony stimulating factor, right? So that increases neutrophil count, that's all, fine? When I say granulocyte monocyte colony stimulating factor, it will increase my granulocytes as well as my monocytes. Okay. Then I have eosinophils as well. Okay. So all these comes from my common myeloid progenitor. So which means when I say an RBC is abnormal, that also can happen when my myeloid progenitor is abnormal, right? So I can have all these. That's why I have so many different subtypes, including my megakaryocytes, including my RBC, including my monocyte. All of them are grouped under acute myeloid leukemia only. I call them AML. ALL is simple for me. AL is either B cell or T cell or NK cell, right? Those are my lymphoid leukemia, that's all. So I have multiple different subtypes in AML, and I have only few things in B or T ALL. That's simple ALL, fine? So now have a look at AML. Since you know multiple different subtypes are there, we'll have a look at each of the subtypes. First, let's say AML M0. See, these are the older variation of classification. Almost every new classification is based on my genetic analysis only. Recurrent cytogenetics problem, I'll say AML, translocation 821. Very simple. That's all we do as of now. But this is required at least for an undergraduate perspective, because this can be asked in a Viva or in an MCQ. Different subtypes, what do I see in the microscopy, fine? When I say AML M0, M0 is AML with minimal differentiation. Okay. There's no differentiation at all. When I say AML with a minimal differentiation, it comes very higher up in the hierarchy, right? It's going to come from a pluripotent hematopoietic stem cell, right? The origin is the main problem always. The origin here is in pluripotent hematopoietic stem cell. So I'm just going to go up once. Let's assume it is originating from this part. So can I say that this leukemia might have the characters of both my lymphoid as well as myeloid, because they are very high up in the hierarchy? Possible. You can have both the characters, right? So the characters is determined by my immunohistochemistry markers or my CD markers. I can have possibilities of both of them. So only the immature markers will be positive. None of the mature markers will be positive, because everything here is immature cell. And the stem cell marker, I'm sure you know what is the marker for stem cell, which is CD34, right? CD34 is a marker for stem cell, so only that will be positive. And we have one more thing called HLA-DR. That also is an immature marker. That also will be positive. I won't have any myeloid or a lymphoid marker positive. In other words, CD19-20 will not be positive. CD3 will not be positive. Only the immature markers will be positive here, right? So I do have a leukemia. I know it is a blast. The blast is very immature. So the CD marker which will be positive is CD34 positive, HLA-DR positive, and no mature markers will be positive. Okay, there will be no mature markers which will be positive, only the immature markers is going to be positive, fine. So I'm having a leukemia which is having the phenotype of myeloid as well as lymphoid, nothing mature but immature. So if I give a chemotherapy for an acute myeloid leukemia, will the stem cells get destroyed? I'm killing myeloid, but lymphoid can survive. It's very immature, right? It's not targeted at all. So my therapy is not so effective, right? So they do have a little bit of a poor prognosis. They're not good because it's not matured anyway. I don't know whom to kill, what to kill. I cannot give both the chemotherapy, the patient will die, right? So it's very undifferentiated, kind of has a poor prognosis, okay? Welcome to AML M1 and AML M2. So you saw M0, then we'll go to M1 and M2. So when you come to M1 and M2, both AML M1 and M2 is based on the differentiation. It's based on the maturation, not the differentiation. Here, both of them are behaving like myeloid lineage only, which means a perfect granulocyte-like lineage, a neutrophil-like lineage, right? Here I say AML M1 is without maturation, and AML M2 is with maturation. Okay, that's a main difference here. One is not having a maturation, other one is kind of completely matured. What is the mature lineage in a WBC or in a granulocyte? Neutrophil, right? Immature is blast. When I say without maturation, the amount of blast is more in AML M1, which means the amount of blast is going to be greater than 90%, which means the mature lineage will be less than 10%. Here my amount of blast is less than 90% and the mature lineage is more than 10%, which means AML M2, I can say that the blast percentage can be even 25%. Mature lineage can be rest of it, 75%, right? It's less than 90, but here it is more than 90. When these are true, of these two, which you think will have a very, let's say, an high tumor load? AML M1 or M2? Which will have a high tumor load? Obviously, it will be AML M1, right? AML M1 will have a higher tumor load. When the tumor load is more here, obviously the blast is more, the tumor load is more, so obviously they don't have a good prognosis, right? They have a poor prognosis. This kind of a less tumor load, so comparatively good prognosis. And AML M2 is one of the commonest subtype of AML. If I have to subtype AML to AML0 to M7, M0 to M7, the commonest one is AML M2, fine? So I know it is myeloid differentiated, right? Once I know it's differentiating by myeloid, I need few markers. I cannot look at the microscopy and say this is myeloid. Though granules help me, I have to be very sure that granules are myeloid granules or neutrophil granules, right? So how do I appreciate a myeloblast? Because this is what I'm going to see in the microscopy. What all features I'm going to look in the myeloblast, and what are the marker profile I need for a myeloblast. First, all these are tumor cells. The first thing what I'm going to see is they are going to be bigger than a routine RBC. The minimum size is going to be 1 to 2 times of the size of an RBC. Okay, twice the size of an RBC. That's first important thing. Second thing is my granules. I have lots of granules here. Not only granules here, I do have OR rods also. See, OR rods are nothing but granules which are condensed in the formation of OR rods. Once a question came in an I don't know which exam it is. OR rods are composed of what? One of the options was primary acidophilic granules. It's lysosomal granules, right? All the granules are lysosomal. They are acidophilic granules only, right? So granules are more important for me. That's important, and they do have OR rods. OR rods are nothing but the same granule content. The morphology is in the form of a rod. That's it, fine. It's primary acidophilic granules only, fine. I generally don't prefer you to understand how the nucleus will look, the amount of nucleoli. That might not be important for you. For you to identify granules present, myeloid blast. Granules absent, lymphoid blast. That should be more than enough for me, fine. So this is by morphology. I'm not comfortable with morphology alone. I do need markers as well, fine. So call it a myeloid lineage. We have two markers. One is MPO, SBB. And we do have CD markers as well. CD. Okay, Nishant, when you go to TNM staging, yes, M1 means metastasis, right? When I go with acute myeloid leukemias, the staging is the naming is totally different. So here we have subtypes from M1 to M7. Those are totally different, right? For a solid malignancy, yes, M1 means metastasis as per TNM classification. Okay. So now come back to this. I do have CD markers as well. CD13, CD33. Okay. Once there came a question that of MPO and SBB, which is better? Again, we are going to go with simple logic and we'll try to understand which is better. When I take MPO, MPO is a granule content of the WBC, right? Of the neutrophil. Let's take a neutrophil. Let's draw a neutrophil. So this is going to be a neutrophil. Here I do have granules. They are all lysosomal granules, right? They are all lysosomal granules. When I say lysosomal granules, the lysosome is nothing but a cell organelle which has the enzyme inside. The enzyme which is present inside those granules are MPO. What is a stain? What does SBB stain? What is an SBB stain? SBB stains your fat, right? SBB will stain a fat. So what is going to happen is, if I'm going to zoom this granule, this is how a granule looks. Granule is a membrane bound vesicle inside which I'll have the enzymes, right? So SBB will stain the membrane. It's a membrane stain. It's a fat stain, right? MPO stains the granule contents. Okay. So can I say that SBB is Sudan black B, obviously. So can I say that definitely MPO is a better stain than SBB? Yeah. SBB is Sudan black B. So definitely MPO is more specific than SBB. See, once you understand why MPO is specific, you're not going to forget ever. It's going to stain the granule content. SBB stains the membrane of the granules. SBB is just a fat stain. It's going to stain fat wherever I'm going to use it for, fine. So if this is true, I'm sure you must have seen a blast which looked like this. I'll draw a blast. Tell me what comes to your mind first. Nucleus with a high NC ratio. I do have cytoplasm which is of sky blue cytoplasm. And I do have vacuoles in the cytoplasm. Which blast looks like this? A high NC ratio blast with a sky blue cytoplasm and vacuoles in the cytoplasm. Which blast will look like this? Yeah, a blast called as in Burkitt's blast, right? Burkitt's blast look like this. Okay, that's how Burkitt's blast looks. When a Burkitt's blast looks like this, Burkitt's blast will have amazing vacuoles in the cytoplasm. So Burkitt's is a lymphoid blast or a myeloid blast? Burkitt's is undoubtedly a lymphoid blast, right? This has to be a lymphoid blast. Okay, so when I take a lymphoid blast, can I say that Burkitt's lymphoma, it has to be a lymphoid blast, right? Now, it's a lymphoid blast. So Burkitt's is a lymphoid blast. Any lymphoid blast will be negative for SBB, but Burkitt's blast is an exception. This will be positive for SBB. Again, Burkitt's blast is one more exception. Burkitt's blast will be negative for PAS. Right? Lymphoid blasts are ideally positive for PAS and negative for SBB. Burkitt's blast is the reverse. Exceptions are always MCQ. The reason why it is positive for SBB is I do have vacuoles. empty vacuoles, right? The vacuoles are full of made of your, hello, good evening Shania. Vacuoles are fully made of my fat. The membrane is also made of fat, right? So since the fat is there, it's going to be positive here as well. Okay, so this is a unique thing I want you to remember. Got it? Okay, so now we were in the AML M2 we saw. Then we look at an AML M3. We look at ALL and we'll see why PAS is positive in ALL. And I do have few more things also where PAS can be positive in AML also. Fine. So take AML M3. AML M3 is a bit unique. I'm sure you must have read about them. Called as an APML, acute promyelocytic leukemia, right? So the origin of this leukemia is not from the blast. It's going to come from the promyelocyte. That's why we call them an acute promyelocytic leukemia, right? The origin is from a promyelocyte. When it originates from promyelocyte, it's not coming from a blast. Which of the markers do you think it will be negative for? When it's coming from a promyelocyte, I don't expect an immature marker positivity. What is the immature marker we saw? CD34, right? CD34 will be negative here. This is an MCQ. This is the only CD34 negative leukemias. Fine. That's one important thing for me. It will be CD34 negative leukemias. Rest almost every leukemia will be CD34 positive. This is CD34 negative leukemia. That's one. Second thing, when I'm saying it's originating from promyelocyte, will I see 20% blast in this disease? Because only when I have 20% blast, I can call that as an acute myeloid leukemia. It's everything is coming from promyelocyte, so I might not have blast. That's an exception as well. Okay. AML M3 is an exception for 20% cutoff criteria, which means I need not require blast. Might be 1 or 2% myeloblast, but atypical promyelocyte, right? Atypical promyelocyte, if you see, that's more than enough for me to diagnose them. They will not be blast, they are promyelocyte because the origin is from the promyelocyte, right? This is one of the exception for my cutoff criteria. Right? So look at the pathogenesis, because when I look at the pathogenesis, it becomes very extremely easy to understand the disease. Not only the disease, I'll all be able to understand or extrapolate my treatment aspect as well, right? So pathogenesis here is, you must have heard, you will have a translocation between 15 and 17. Here I have PML gene which is getting translocated with RARA. The RARA gene stands for retinoic acid receptor alpha. Okay. It's retinoic acid receptor alpha. So once it gets translocated with retinoic acid receptor alpha, this is going to convert to, okay, you'll have a block in the maturation. Because of translocation, it blocks the maturation, or we call them a maturation arrest. That's all. Blocks maturation after my promyelocytic stage. PML stands for promyelocytic leukemia gene, right? I'm writing PML for my promyelocyte stage. After my promyelocyte stage, the cells will not mature because the routine function of vitamin A is maturation. Since the maturation is defective, that's why we have metaplasias in vitamin A deficiency and vitamin A excess. Bite dot spot is in metaplasia. I'm not maturing properly. I mature to the keratinized epithelium in the eye. I call it bite dot spots. So same thing will happen throughout the body. My maturation is going to get altered. Here they don't mature. All of them stop at promyelocyte stage. So when maturation is halted, am I right in saying that in this patient, the neutrophils will not be there? The mature cells, the most mature cell is neutrophil. They won't be there. Yes. They won't be there, right? So if my neutrophils is not there, what my body will think? There is deficient neutrophils. So what will bone marrow do? It will cause more hyperplasia, right? It's like a feedback mechanism. Like my hemolytic anemias and reticulocytes, the same thing will happen here. No mature neutrophils, my body automatically to overcompensate and keeps on producing more and more and more hyperplasia of the bone marrow. So what will end is, because of the block of maturation, there's going to be recurrent or more hyperplasia of the bone marrow. At the end of the day, I'll have lots and lots of promyelocyte. There'll be an increased quantity of promyelocytes in the peripheral smear. We call them an atypical promyelocytes. This causes the problem. This is the tumor, this is leukemia, because promyelocytes are they are very large cells and they do have lots and lots of granules. They'll have at least 4-5 times more granules than a normal neutrophil, an average neutrophil, right? A promyelocyte, see, this is a blast. This is how we drew the blast, right? Nucleus and granules. It's the promyelocyte is the next cell, matured cell next to a blast. So any WBC, especially in the granulocyte, maturation means the nucleus kind of folds on itself, right? This is what happens to the nucleus. It will fold. Then finally what will happen is I'll have lobes, a neutrophil, right? It keeps on folding. So here my nucleus folds on itself. Not only that, I'll have lots and lots of granules for comfort, more than usual, right? Lots of granules which will be more than what I expect, right? So I have cells which will be abundant like this. When I have more granules, will I have more OR rods as well? I'll have lots of OR rods as well. So we gave two peculiar names for these two. One is the OR rods, and I call it, we'll have lots of OR rods, we have bundles of OR rods. These bundles of OR rods were called as faggot cell. Okay, we call them a faggot cell. Second thing for me is my granule contents. I have lots of granules because of the OR rods and the nucleus. The nucleus is called as a buttock-shaped nuclei. It's a folded nuclei on itself, right? The person who saw that, it looked like a buttock, so the person named it as a buttock-shaped nuclei, right? So these two are very, very characteristic for my acute promyelocytic leukemia. I have to pick them up on a microscopy because this can come as an MCQ or it can come as an image-based questions as well, fine? So I have two terms here. I'm having lots of promyelocyte. Then let's assume that all these promyelocytes, will they be in the bone marrow or in the peripheral blood? What is the location of promyelocyte? Normally, promyelocyte will be in the bone marrow or in the peripheral blood. They have to be in the bone marrow, right? Only the neutrophil or my band forms comes in the peripheral smear. Rest everything will be in the bone marrow only. So when they have to be in the bone marrow, now they are being kind of pushed outside because there are too many promyelocytes coming in the bone marrow. I don't have enough space, so I'm going to push them outside my trabeculae. When I push them outside my trabeculae, can the membrane get damaged? They can get damaged, right? So all these promyelocytes must be in the marrow. It has to be in the bone marrow. So once they come outside, what's going to happen for me is they'll kind of get injured. They'll get injured while being pushed outside. Because there is no enough space for me, they'll be pushed outside and they'll be injured. When they are injured, there is a possibility they will degranulate in the periphery. This is a problem for me. When it degranulates, the biggest problem for me when it degranulates is the granules of a neutrophil can initiate. Can a granule of neutrophil cause an endothelial damage? My neutrophil is degranulating. Can it cause an endothelial damage? It will, right? These granules, when they degranulate, they cause endothelial damage. Once an endothelial undergoes damage, will it cause coagulation? It will cause coagulation. It will trigger clot formation. This is a major problem for me, right? It's just granules of neutrophils. They're going to trigger clot formation. Once they trigger clot formation, it is not in one particular area. The granules or the WBCs roam all around my body. So in different parts of the body, they're going to cause endothelial damage. They're going to cause trigger my clot formation. This will end up in DIC. The patients might present with DIC, right? They might present with DIC. So whenever you see a patient of an APML at whatever timeline it is, please tell to the patient, get treated here itself. Because see, we should not blame the patient at the end of the day. Let's assume that APML comes in an age group of 25 to 30. I'll come to Devraj. APML comes in an age group of 25 to 30. You are going to tell to a 25-year-old person, see, you have a blood cancer. Will the person go for a second opinion? Undoubtedly, the person will go for a second opinion, right? So when the person goes for second opinion, goes again more and more and more opinions, at the end of the time, there's going to be a delay of 1 or 2 weeks. When there's a delay of 1 or 2 weeks, obviously there is more risk of DIC formation. This is one leukemia which I don't want to push it further. Please tell the patient, you get the first treatment here. If you're seeing leukemia, get it treated here, then please go for a second opinion. Give a ATRA. I'll start ATRA at least, right? Because there's a few things which if I miss, I might even lose the patient. For breast cancer, I am not in a hurry. Breast cancer would have been there for 10 years, 15 years already. I'm not in a hurry for breast cancer, but few leukemias which are emergency, I want to tell the patient, don't do anything, get treated. Yes, you have unfortunately got a disease, I cannot help. Help with the help of a psychologist or a psychiatrist, counsel the patient and start the treatment and then send the patient outside. Please don't send the patient outside without treatment, fine? Okay, Debraj, what happens is, for me, when it's inflammation, I'm having, let's say if there's a blood vessel like this, okay, I'm having granules here, this part, okay, I can accept inflammation, but the same thing happens all over my body. It will trigger inflammation cascade for sure. Let's assume it is causing inflammation also. The inflammation, again, will it cause endothelial damage? It will cause endothelial damage. That will give rise to a DIC only, right? If you remember the pathogens of DIC, that also kind of same, sepsis, multiple places endothelial damage, inflammation and clotting cascade is more or less one and the same. They are interlinked, right? So I won't have an inflammation per se, yes, I'll have fever as a byproduct of the inflammation or the clotting cascade activation, fine, okay? So I'll have to diagnose this patient. So your appearance of that, I hope, and an image of that, I'll ignore this for now. Look at AML. Can I call this horror? I just want to look at the APML slides and then we'll go back to the theory part. Yes, this is definitely an horror. The single small strike, that's an horror. I'm not seeing much of granules here, but it's fine, I'm seeing an horror. It's diagnostic of an AML, right? Second thing here, when you look at this cell, this definitely there is lots of horrors, right? Bundles of horrors, I call them a faggot cell. I'm having lots of horrors. This could be an AML M3 or an APML, right? Acute promyelocytic leukemia. When you look at the nucleus here, definitely this part of the nucleus is much cleaved nuclei, right? You're seeing the indentation here. This one, this one, this one. They are deeply cleaved nuclei. This is called as a buttock shaped cell. Both of them are spotters. For undergraduate, we want them as a spotter, a buttock shaped nuclei, and lots of bundles of rods, which both of them are diagnostic of APML or an AML M3. Okay, go back to the theory part. Fine. So I have diagnosed AML M3 and I have to treat the AML M3. And I have two arms of treatment. Ideally, the best way to treat AML M3 is I have to do both. Simultaneously, I have to do both. If both are done, the incidence of complication is a bit less. When you know about the treatment, we can easily understand that incidence of complication will be less if both are combined and given. One treatment is ATRA. Second is arsenic trioxide. Because it's a maturation defect where I'm having a mutation in the retinoic acid receptor, it's like a simple competitive inhibition. I increase the dose of retinoic acid, the inhibition goes away and the maturation is going to continue, right? I need arsenic also. See, this is going to take away the bridge of maturation errors, so automatically it matures. It causes maturation, or it promotes the maturation of promyelocytes. Here, arsenic is a heavy metal. They act like a chemotherapy agent. They destroy the promyelocytes. They destroy promyelocytes. That's what they do. Fine. I need both. I'll tell why I need both. If I'm going to give ATRA alone, let's say that for example, the patient has 50,000 promyelocytes per ml of blood, and I'm going to give ATRA. Can I say that at least 50% of them will mature, just for rough sake, which means 25,000 WBC is going to mature in a single turn, right? Within few hours per ml of blood. So the entire 5 liters of blood, I'm going to have millions of WBC which is going to mature immediately. They become neutrophils immediately. When they become neutrophil like that, is there a possibility these neutrophils can go and get stuck in the lung capillaries, some tiny capillaries, clog? When it gets stuck in lung capillary, can it cause an acute lung injury or like an ARDS like situation? It can happen. That's a problem. Plus these WBCs are already weak WBCs. They might even degranulate. Here I might have it can get clogged in the lungs. We have a differentiation syndrome or an ATRA syndrome, which is an acute lung injury because of sudden maturation of these promyelocytes into neutrophils, right? When there's a sudden maturation of millions of cells throughout the blood, these neutrophils can go and get clogged in the lung capillaries. They can block the lung capillary. They can cause inflammation of the lung capillary. This I'm going to call it an acute lung injury. Like an ARDS, that's all. It's an acute lung injury, it's an ARDS, which can happen post-ATRA. We call this a differentiation syndrome. In your medicine, you will read more about differentiation syndrome or an ATRA syndrome. there's something I should always look for whenever I'm going to give the patient ATRA. The way to treat them is I kind of give steroids. When I give steroids, it's going to reduce the WBC amount. That might help the patient a little bit. The second, why I said if I give a combination it will be better is, here I'm giving arsenic. Let's assume the same 50,000. I'm giving arsenic, it kills half of the promyelocytes, just for an assumption. Only rest half is present. So the amount of neutrophils which matures will be less than usual. So giving arsenic along with my ATRA kind of reduces my differentiation syndrome. It's just a normal understanding. If I treat it suddenly, it might have a problem. So I'm going to do this, right? APML, if diagnosed early, has the best prognosis. There are places where APML can be cured, right? I'm not saying it will always be cured. There are instances I can cure APML. The patient can have a very, very good prognosis on a long term if I diagnose before DIC. If DIC sets in, it's kind of almost impossible to cure APML, right? It is gone. I'll not be able to do anything unless and until if the patient is lucky, revives from the DIC, then maybe I'll treat the leukemias, right? Okay. That's about our APML. Let's just have a quick look about just a few words about AML M4, AML M5. So when I say AML M4 and M5, first is my AML M4. AML M4 is my myelomonocytic leukemia. AML M5 is pure monocytic leukemia. We do have criteria to diagnose AML M4 and M5 based on the amount of monocytes and amount of myeloblast present. For an undergraduate, I would say don't go into it. Go into the depths of it. There are few things I want everyone to remember about AML M4 and M5. Both M4 and M5 has a monocytic component. It will be there. M4, it's myelomonocytic. I have both myeloid and I have monocytic, right? So when I have myelomonocytic component, what I'm going to do them is, it's monocyte. Generally myeloid or the neutrophils will be there inside my blood vessel. Monocytes, can they go into the soft tissue? They can go into the soft tissue, right? So we have a myelomonocytic component. I do have soft tissue involvement as well. These soft tissue involvement, we call them a chloroma, right? We'll come to a conclusion why I call it a chloroma very soon, right? So this monocytic component can spread to the soft tissue very easily. Okay. When I can spread to soft tissue, in the soft tissue, I can have blasts. Soft tissue in the sense it can be in the skin, leukemia cutis, in the lymph node, in the retroorbital space. There are many places I can have leukemias, right? In the gum hypertrophy, that's also one of the classical presentation, right? It's a soft tissue where I have the blast going inside, right? So soft tissue leukemias can also be there in AML M4 as well as AML M5, right? I know, right? So what's going to happen here is I need to know about this. So we have myelo and monocytic. We already read two markers for my myeloid lineage, which was SBB and MPO. Here I'm going to add one more marker for myeloid lineage, which is called as an chloroacetate esterase. Okay, there are two types of esterase. I'm sure the other esterase you must have known, you must have heard about non-specific esterase. Okay, we have a non-specific esterase is one person, chloroacetate esterase is the other person, right? Because of the chloroacetate esterase positivity, we call these soft tissue lesions as the soft tissue blast as chloroma, right? Its oma is swelling. So chloroma is nothing but when you have soft tissue blast, we call it an chloroma. It's the same leukemia. Whenever I have blast in any soft tissue, I call it an chloroma because of the chloroacetate esterase positivity, right? So we had one more term as well. This, if it's asked, it's an older terminology. Which came once in an older exam. If it's repeated, it might be helpful because most of the senior professors like this term. AML M4 M5, it is positive for both the esterase, chloroacetate esterase and non-specific esterase, right? So we call them a double esterase positivity. Any question which says double esterase positivity, think of AML M4, which is myelomonocytic leukemias, double esterase positivity, fine. Okay. M5, I'm going to have predominantly monocytic component that also can cause chloroma. That also will have the incidence of soft tissue involvement as well. Right? Now let's have a quick look about just few things, then we will call it a day. I want to just start about ALL because AML M6 AML M7 and ALL kind of has one common thing. That's what I'm going to talk here, PAS, fine. So in everywhere here, PAS and leukemias. Again, I don't want you to memorize anything. If we understand the basics, we'll be able to extrapolate and remember for a longer time, fine. PAS is a stain seen in which leukemia? ALL or AML in general? I'm just going to give a history of PAS positivity. What will come to your mind first? AML or ALL? Obviously, ALL will come to our mind first, right? ALL is a positive for PAS, fine. So PAS, if you remember general pathology, it can be used in multiple places. PAS will be positive in protein. PAS will be positive for glycogen. PAS will be positive for my fungal tissue as well, right? PAS can be positive in many places, right? So I'm going to take that PAS and I'm going to apply for different blast, right? So if you remember PAS, it will be useful for glycogen. We'll take this first and then let's have a look about leukemias, about lymphoblast. When I take a lymphoblast, just a lymphoblast. A lymphocyte is a mature cell or an immature cell? It's a mature cell or an immature cell? Any lymphocyte is an immature cell, right? It is immature. It's an inactive cell, not immature. It's an inactive cell. Lymphoblast as well as lymphocyte is an inactive cell, right? It's not immature. I wanted to say about inactivity, right? Only it becomes active when it is going to become a plasma cell. Otherwise, it's an inactive cell, right? Lymphocyte is a mature cell, but it's an inactive cell. Okay? So lymphoblast is also inactive. Can I say that at one point of time, the lymphoblast will become a lymphocyte and it will mature to become a plasma cell? Obviously, that's obviously the ultimate goal. So when it matures to become a plasma cell, that time I need energy. I need energy to produce proteins, antibodies. So can I say that these lymphocytes will store the energy reserve? Yes, reserve form of energy for any cell is one of the reserve forms is glycogen. So what happens is a lymphoblast, if let's assume this is my lymphoblast, it will store my energy. It's an inactive cell. It's going to store my energy in the cytoplasm in the form of a glycogen vacuoles. They'll store glycogen like this, fine. No, lymphoblast is immature only. They are inactive, right? I just got confused between mature and immature term, fine. Okay. So this glycogen will be positive here. And the glycogen positivity will be in the form of a dot. So we call it an block positivity. Block or a dot-like positivity. Fine. So that's one reason why PAS is positive in a lymphoblast. That too, the basics of positivity will be a dot-like positivity. Fine. So let's take Burkitt's blast. Burkitt's, just now we saw, right? Burkitt's is a lymphoblast. Burkitt's lymphoma. I do have a Burkitt's blast in Burkitt's lymphoma. So when I say Burkitt's blast, one unique thing about Burkitt's lymphoma is the proliferation rate. The proliferation rate of Burkitt's lymphoma is less or more compared to many lymphomas. What do you think will be the proliferation rate of Burkitt's lymphoma? It will be extremely highly proliferating, right? That's one unique thing about Burkitt's lymphoma. They'll proliferate a lot. So what it is said is Ki67, which is the proliferative index of Burkitt's lymphoma, is close to 100%, right? Burkitt's proliferates like anything. A cell comes, divides, again it will enter the cell cycle, divides again, enters my cell cycle, divides again. They don't even rest. They keep on dividing like that. So if you have a cell dividing very fast, can I say that the glycogen stores would have been utilized? Do I need glycogen or energy for cell division? I do need energy, right? So if that is true, will Burkitt's blast be PAS positive? The glycogen stores will be used up for division. When their store is used for division, Burkitt's blast should be PAS negative, right? Again, that's a unique thing. It's a lymphoblast, but they are PAS negative. We can go logically for everything, right? They'll be used up everything, so PAS has to be negative, right? That's again true because it's very fastly dividing. I'll come to M6 and M7. Fine. Same PAS. As I said that PAS will be positive in proteins as well, right? We'll take AML M6. AML M6 is erythroleukemia, right? If you remember RBC lineage, there is a very early precursor cell called as an proerythroblast. In the proerythroblast stage itself, what will happen is I will start having your hemoglobin. hemoglobin is a protein. Am I right in saying that hemoglobin will be positive for PAS? Proteins will stain PAS, right? So even in the earliest blast is my proerythroblast in the RBC lineage. Even in the proerythroblast, I will have hemoglobin formation, fine? Okay. I'll have hemoglobin formation, okay? Fine. So when I have hemoglobin formation, I'll answer your question RNP. Just a second. We'll finish this and definitely answer your question. If you're still there till the time, I'll definitely answer your question. Fine. So in the proerythroblast formation itself, I'll have hemoglobin. So once I have hemoglobin here, hemoglobin will be PAS positive. Now tell me, hemoglobin in the cytoplasm will be distributed all throughout or it will be in local pockets only? Hemoglobin will be distributed all throughout, right? So PAS here will be positive all throughout. I'll have PAS positivity here throughout the cytoplasm, fine? So I call this in circumferential positivity. Okay. I'll call this in circumferential positivity. It will not be dot-like because I cannot expect a hemoglobin to be only in one dot, right? It should be circumferential all over, all surrounding the cytoplasm will be positivity. That will be a very classical finding for an erythroblast. Now let's have a look at the other one, AML M7. AML M7 is megacryoblast, right? How are platelets formed? What is the mechanism by which platelets are formed? Mechanism by which platelets are formed? Formed by pinching off from the cytoplasm, right? That's how platelets are formed. So platelets, if you remember, they have lots of glycoprotein on the surface. Glycoprotein 1b9, glycoprotein 2b3. So if platelets have glycoprotein, can I also extrapolate that megacryoblast, the immature platelet, will also have glycoproteins in the cytoplasm? It will have, right? So can glycoprotein be positive for PAS? They'll be positive for PAS. So let's take, it's a megacryoblast, fine? A megacryoblast will be positive for PAS as well. But the way of positivity will be totally different because megacryoblast will have glycoproteins which will be positive. So when I have a nucleus like this, the glycoprotein here will be not uniform, will not be in a corner, will be distributed like this, right? Because anywhere, whenever a platelet is formed, they're going to pinch off from the cytoplasm and take a little bit of glycoprotein and go outside. Here you'll have a granular positivity. When it's a granular PAS positivity, which is going to stain my glycoproteins, that's how an AML M7 PAS positivity will look, right? See, all are same PAS. PAS has different capacities. It can stain my glycogen, it can stain my protein, fine? See, when I say diffusely granular, see, the thing about granular is, Devraj, it should not be a very huge dense granule. Sometimes I can have, I'm just going to lymphoblast, I can have two granules, that's fine. Unless it is uniformly distributed throughout the cytoplasm, I cannot call it a megacryoblast. It's localized to one place, they are glycogen deposits only, fine? Okay. The granular, you want large granular leukemias. If you're talking about LGL, LGL is totally different one. We are talking about PAS. PAS staining is different from our original granule, which is seen in routine Leishman staining, right? Those two are totally different ones. So here in PAS, if it is uniformly distributed all over the cytoplasm, I call it megacryoblast. Plus, fine. So PAS has dot-like positivity in your ALL, no positivity in Burkitt's lymphoid blast, circumferential positivity in M6, and granular positivity in M7. This is how a PAS looks, fine? So different applications of the same stain in different place locations, right? I think I had an image for your lymphoblast. This is how PAS positivity of lymphoblast will look. A dot, maybe two dots, but it will not be distributed all over. It's just a dot-like positivity, fine? Block positivity of PAS or dot-like positivity is a diagnosis of one lymphoid blast, fine? Next one, just have the image for your M6 as well. See here, it's a cytoplasmic blush-like positivity, right? See here, the entire cytoplasm is positive because of my hemoglobin. It's the same PAS stain. Here my diagnosis, AML M6. It's the entire cytoplasm positive. That's how it will look for in my AML M6, right? I don't have an image for an megacryoblast. Maybe I'll share it in the Telegram group, right? Okay. So a few things which I want to discuss in today, and just for those who came late, you will have a test tomorrow at 9 p.m. The questions are given for them to the team. They'll have uploaded it. It'll be based on RBC and WBC, not exactly like what we read here. Something related to that, an extrapolation of that. We'll have a test, and if you are able to come in top 3, you will get vouchers. Fine. Okay. Any doubts? If any doubts, let me know. If not, we'll call it a day. No doubts? Okay, great. If you have no doubts, we'll call it a day. Hopefully, let's see. It'll not be like huge integration. You are second year, you can still write the exam, because I'll answer technician 99. See, it will be a clinical exam pattern question, which you can easily identify with the help of the basic thing which you studied in your leukemias. Fine. Okay. Don't worry, you have to give the exam, Debraj. It's fine if it is an integrated question which you're not able to answer since you're second year. It's completely fine. You can answer it later on in term, right? You'll learn from them. That's all. Fine. Okay. For technician 99 RMP, thank you RMP for that. See, at one point of time, you have to take a decision whether you have to stay at home or you have to roam around. That's one major hinge for me to leave the previous institute. It was a very good place to work, but health condition, one, and second thing for me is when family comes inside. Family is important, right? So it is too much of travel on every weekend. This is more comfortable. I can do my work as a pathologist, which I love more. I'm working as a molecular pathologist in Chennai, so I cannot leave that. So it was kind of hinting on that. So that's the reason I came here. Okay. Fine. Thank you for your time. Yeah, work from home for teaching, and I can go to the lab and I can diagnose them as well. So it gives me the pleasure of both ends. So it's good to work from home. Thank you for your time. Bye-bye. Yes, Debraj, ask me. The app in the Play Store might not have the subscription. It will be there. There are only few free videos, that's all. Fine. If there's no notes in the Play Store app, it's just an app with few free videos. Maybe I'll put a few tests in down the road. It might help you guys. Since I've moved to Unacademy, the subscription might not be available. Fine. Thank you guys. Thank you for your time. See you soon. Bye-bye.